Okay, so Dr. Lutz holds an appointment as adjunct faculty for the Elson S. Floyd College of Medicine and the University of Washington School of Medicine in Spokane. Dr. Lutz will talk for 40 to 60 minutes and then he'll take questions and answers from the audience. We ask that you please hold your questions until the conclusion of his talk, and then we'll have microphones on each side for people to ask their questions. So without further ado, let's welcome Dr. Bob Lutz.
Well, good evening. As Dave said, this is a totally unprepared talk, even to the point that I am co-opting a PowerPoint presentation that was presented yesterday to the State Board of Health. I had a very different presentation planned. Dave and I had talked, and really what I wanted to talk about was social injustice, issues around what I'll call the injustice system associated with incarceration and mass incarceration, especially what we're seeing in our community, but across the nation, and then also climate change as an issue of social injustice. But this came about. And so it's certainly been a whirlwind couple of weeks. This past week, I feel like I'm back in internship with very little sleep, and I do a lot of walking. If I had roller skates, maybe I would be roller skating, but it's definitely been very, very busy. The thing that I think one of the take-homes I want people to realize today, and I think maybe it's a misperception, a lot of times over the last couple of weeks you will hear that this is being compared to flu, and people are saying, well, I mean, it's just the flu, it's just a cold virus. And I would say that's not quite accurate. I mean, does it present similarly to flu? Yeah, it does. I mean, and so it's difficult to differentiate whether someone has the flu or whether someone has COVID-19, but it is a very, very different animal, a very, very different bug. And so again, we'll talk a little bit about that. So bear with me again. This PowerPoint, literally, I co-opted at about 1700. And so I did add a couple of slides to it, but as I said, this is sort of a new presentation for me, so bear with me. So what do we know about COVID-19? It obviously came on to the world's stage back in December. And I don't know how many of you were following it back then, but certainly it made a significant mark at the world level when all of a sudden you hear about this outbreak in a wild animal market, in a wild animal food market in a city called Wuhan, which had a population of 11 million, in a province called Hubei. And I did not know where Hubei was, but I do now. And the interesting thing about this was that this was not unexpected. The coronaviruses, cold virus, are actually a family of viruses that unfortunately or fortunately are endemic to bats. And it's fascinating. Bats have an incredible metabolism, and it's thought that at some level their metabolism makes them almost immune to these viruses that otherwise can be very, very pathologic for a lot of individuals as well as other animals. But their metabolisms are such that they're able to maintain these viruses, but they shed them. And in these wild animal markets, as I'm sure you're well aware of now, unfortunately, close proximity of multiple species of animal in close proximity to humans makes the transfer of a virus to an intermediate host all that more common. And that's what we've seen with SARS and with MERS, Middle Eastern Respiratory Syndrome. And the fact of the matter is what we call zoonoses, i.e. infections that are coming from animals. Flu. Influenza is a virus that begins in animals, but it has an intermediate host and then is transmitted to humans. And again, we're seeing more and more of these. So just an aside about when you look at climate change, with climate change and the proximity of humans to animals they've not maybe been exposed to in the past, and or changes in climate, we are going to see more and more of these types of infections. So this is just unfortunately probably a harbinger of what we're going to be seeing in the future. I'm going to skip the situation update because I've got some slides to show about that later on. And again, what we're going to be talking about again is again focusing on the efforts here in the state. Oops. So COVID, it's a coronavirus, cold viruses. There's actually 4 strains of coronavirus that are endemic, meaning that they occur commonly in humans. And again, they occur seasonally, but they're endemic. All of you have been exposed at one point in time to all 4 strains, and probably multiple times. As I mentioned, we're calling it novel because it was indeed novel, but quite honestly, it was identified by a researcher in a Chinese cave in bat guano a decade ago. So it was known, it just hadn't been seen in humans. As I mentioned, it's related to the SARS virus, sudden acute respiratory syndrome. And again, the animal is bats, specifically the horseshoe bat, and the intermediate species has been thought to be the pangolin, which is a cute little animal that unfortunately is also a purported medicinal animal for Chinese medicine. So early on, this is a respiratory pathogen, and it wasn't sure as to how it was passed on from person to person. We were talking about aerosolized, and so, for example, a lot of infections are aerosolized. Tuberculosis is aerosolized, measles is aerosolized, meaning that it's not just respiratory droplets, but it's actually fine particulates that, again, are transmitted in the air, that just sort of hangs out in the air. Then it was thought that it was respiratory droplets. Respiratory droplets are what you see in that classic image of this person sneezing in slow motion, and all of those droplets come out. And again, during coughing and sneezing. That'd be great and really simple if it was just that. Unfortunately, we've also identified asymptomatic spread. And I was talking with someone today, and they've actually shown in some laboratory studies that the particulates can remain aerosolized for up to 3 hours in a room. So, again, I joke about doing this because I do it all the time. I see your hand there, sir, but I would discourage you from doing that in the future because that's one of the means by which it's transmitted. Respiratory particles around the eyes, mouth, mucous membranes. They say theoretical transmit through fecal oral, and only in that they've been able to find actual viral particles in these fecal specimens that were found in the animal markets. But there's no evidence right now that it's really transmitted that way. Median incubation, about 5 days, but 2 to 14 days. And unfortunately, there's a period of time when people are asymptomatic and yet are actually have the virus and may be transmitting the virus, which again makes it really complicated from our standpoint. Again, probably most infectious when they are symptomatic, but again, not quite sure. Again, talking with folks today, and I'll just mention this now, virus is very interesting. We've seen people who have quote unquote cleared the virus who then have had a recurrence a couple weeks later, up to a month later. And it's also been shown that this virus is incredibly, incredibly efficient. Viruses essentially are of 2 types. They're incredibly virulent, meaning that they kill a lot of people in a very quick, short period of time, like Ebola, or they're very subtle, and they just sort of hang out, and they infect a lot of people, and they make a lot of people sick, but don't kill a lot of people. That's this virus. And it's a single RNA strand, meaning it's readily able to mutate. And so, we joke about it, and this is not a good joke at all, but I talk about coronavirus 2019, but it could be COVID-19 2.0, in a couple of years. We just don't know. That's why it's novel. We just don't know how this virus is going to react. Is it going to back off during the spring and warmer months? A lot of cold viruses, as you know, are much more common during cold weather. It's thought that it may pass that way. Who knows? TBD. So the classic symptoms are, again, not uncommon from any respiratory bug that you will see during this time. So again, we focus on fever, we focus on what we call lower respiratory tract symptoms, sort of below the neck. So chest congestion, coughing, shortness of breath. differentiating from upper respiratory tract infections and a sore throat. That said, we're now starting to see some of those symptoms mixed in with this as well. It's not clean. Concerning that, again, it may progress. This is a continuum. The majority of people, as you I'm sure are well aware, are asymptomatic or mildly symptomatic, 80+%. But there's a 20%, 15 to 20% that are really symptomatic, end up being hospitalized, and maybe 5% end up going into requiring ICU and maybe even death. And again, risk factors seem to be older age, males who smoke, and statistically significantly worse in this population. Over the age of 60, you have about an 11% mortality rate. If you're 80 and you come down with this virus, maybe a 35% mortality rate. And that's again based on studies that we've seen from China. I'm going backwards. So I mentioned that, and then comparison to MERS, which is Middle Eastern Respiratory Syndrome, again another coronavirus, SARS, which is 10%. MERS is still sort of circulating. There was actually a reported case of MERS a couple of weeks ago. SARS we haven't seen for quite some time. But again, much higher mortality rates. Look at H1N1. That was the last, quote, pandemic. It never really materialized to the degree that we thought it was, but again, a much lower mortality rate. COVID-19 estimated to be 2%. It could be 2 to 3 or 4%. Right now, it's difficult to get what's called a case fatality rate on this because we just do not know how many people actually have the virus. And so I need a denominator to be able to give me a rate. And if I don't have a denominator, then it's somewhat hypothetical. But what we do know right now is that it's estimated between 2 to 3 to 4%. In the Italian outbreak right now, it's estimating around 6%, which is pretty significant. H1N1, that was a pandemic flu, less than 1%. So whereas right now I have millions of people who have been diagnosed with flu in this country, and I've had tens of thousands of deaths due to flu, the rate of death to flu is much, 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 much lower. Will I have overall greater numbers of people succumb to the flu? Yeah. But at a rate much less than what we're seeing for COVID-19. Pretty upbeat conversation, isn't it? Welcome to my world. It was funny. I've had the chance, you may know, I get a chance to write for the Spokesman Review on a monthly basis. And, you know, the world I live in is pretty heavy. And I thought, you know what, Bob, I'm going to write something upbeat for the holidays. And so I wrote about being grateful. You know, nice thing, nice, you know, there's a lot of health benefits of being grateful and all that. And it didn't get published. And I was like, I'm looking for it, I wonder why it didn't get published. And the editor got back to my public information officer and he goes, you know, that's not just what we expect from Dr. Lutz. Tell him to stay in his lane. And it's like, okay, so Bob's going to be kind of heavy and dour. Okay, so bear with me. So here's my political statement, of which I have many, but I'll hold it to this one right now. We are behind the power curve in a big, big way in this country around preparedness and in being able to test effectively for this virus. You know, so I think about the fact that it was diagnosed, it was confirmed, we knew about this, we had a genetic identification of this virus within weeks that was publicized, that was made public. You had researchers working on testing, you had researchers working on how to diagnose this. You had test kits that were made available by the World Health Organization months ago, and yet for some reason it wasn't happening here in the States. I don't understand. But apparently test kits made overseas and approved by the World Health Organization aren't good enough for the CDC. So when I started getting people diagnosed over here, case in point, the individuals who were on the cruise ship, I had to have confirmation tests through the CDC. Are you surprised to find that they actually confirmed that the tests performed elsewhere were accurate? But The problem here now is that I've got a huge backlog of tests. I've got a huge backlog of individuals who could be tested. As of today, in Spokane, I've tested 15 people. I have results back on 15 people. All negative. 15 people. How can I tell? I mean, again, I was quoted as saying that it's here. I know it's here. I just don't have documentation that it's here. I have no doubt that statistically it's here in Spokane. It just makes sense. Why would it not be? Think about how many planes come back and forth between Seattle and Spokane on a daily basis. I've had 15 tests results in 2 weeks. It's kind of frustrating. And although we're testing at the public health lab, the initial reagents that they sent to the public health lab weren't working. We couldn't validate them. So it ended up having to go back to the CDC. And then when the tests came online at the University of Wisconsin, we couldn't validate those. So there was a backlog of tests of over 800 last week at the public health lab. So now I have private labs like LabQuest, like Quest and LabCorp that have come online, but LabCorp sends its specimens to either Tennessee or South Carolina. So I got to get a FedEx, send it back, turnaround time 5-7 days. In the meantime, I'm having somebody self-isolate and hang out at home. You know, so it's been a challenge. And so, you know, when it hit Seattle really, really hard. And as you probably heard, there was evidence, or at least anecdotal evidence, that it was there, but we had no means to confirm it. And then when it hit, it had been sort of percolating at the community level probably for weeks. And when it hit really, really hard. And who did it hit? It hit people in the assisted living facility. And those are our most fragile, our most susceptible, our most vulnerable individuals. And the deaths have primarily occurred in that population. So again, my editorial comment, we've been hamstrung and hindered in being able to provide an adequate response in a timely fashion by some of the challenges that confront public health and some of the politics that unfortunately sometimes cause public health to have to struggle with what we're attempting to do. So as you know, there's no vaccine, there's no treatment, there's some experimental antiviral medications that are being used, but nothing right now has been shown to be effective. And so therefore it's very supportive management. Again, you know, if you have mild symptoms, you're going to do the same thing you do for a cold. I'm going to tell you to go home, I'm going to tell you to drink plenty of fluids, you know, cough into your sleeve, don't rub your face, you know, cough, respiratory etiquette, chill out, and don't infect others. But obviously there's that percentage of individuals who end up hospitalized. And one of the concerns that we're seeing is that when you have a large number of individuals who succumb to this infection, who get sick at over a very short period of time, you all of a sudden have a system that's being overwhelmed. And we'll talk about that in a bit. So, I mean, as I mentioned, antiviral medications, vaccines, I really hate the rhetoric that, oh, I'll have a vaccine in a couple of months. No, we're not. It doesn't happen like that. So if we see it in the late fall, if we see it next year, we'll be lucky. And again, the technology is so much different than what it used to be for making vaccines. And so I think they will be able to develop a vaccine, but it's not going to be coming around anytime soon. Tell me if I'm going the wrong direction. I think so, yeah. So this is as of this afternoon at 4:40. So total cases about 128,000, deaths, you know, individuals, and again, it's a world map. So again, I don't have the map, but again, imagine if you go a little bit farther into China, that's where the majority of cases still exist. So 80,000 of that 128, so, you know, 3/4 are in China. Incredible rapid event in Italy. You know, they've shut down the whole country. A couple weeks ago, obviously, the young students from GU were able to get back here in the nick of time. They wouldn't be able to do that now, but I mean, it's been totally shut down. And in talking with people over there and talking with healthcare providers, overwhelmed. I mean, they are in, we call it crisis standards of care, where you literally do not have enough ICU beds, ventilators, and so you're having to make those very, very tough decisions. Who gets what? and why should this person get that resource whereas they shouldn't somebody else. This is where we are right now as of, again, 4:45 when I was putting this together. 1,300. The majority, unfortunately, as you know, are here in Washington State. Almost all the deaths have been in Washington. Oops. And then again, as of this afternoon, when I looked at this, we have 457 with a lost the light up here, with 31 fatalities. So again, a little bit here in Washington State, maybe the numbers are a little bit discrepant. 13 counties, most in King County, but 13 cases as of now, unassigned. So I've got 46 test results that we have not, and these are confirmed positives that haven't been assigned to specific counties. So stay tuned. We get reports, then we've got to go through it. The system is a little bit challenging, but essentially what we have to do is we have to match the number with the zip code to kind of figure out exactly what county this individual is in. And so 15 cases that, I should say 15 negatives, I'm not a betting man, but I'll venture to bet you that one of these 46 unassigned is somebody from Spokane. And so people are just waiting for that first confirmed case. I'm not sure why, but it means a lot for folks. But again, I'm betting it's in this group, so maybe tomorrow, maybe over the weekend, you'll hear that Spokane has its first case. So I'll be talking about what are called non-pharmaceutical inventions. As I mentioned, there's no vaccine, there's no medications for this. And if I was a good academic, I would have a laser pointer that I'd be able to point out something on this curve. But what I want you to take a look at is, again, this curve represents a pandemic. And the two curves essentially are, the first curve is when you have no intervention whatsoever. So you see a very steep acceleration. You see then that sort of similar rapid decline. No interventions, nothing. No non-pharmaceutical interventions. What we try to do, however, is to shift the curve to the right, and in doing so, sort of delay the onset of presentation and also decrease the peak and delay sort of the overall response. And so really our effort right now is on moving that curve to the right and lowering the peak. And that's what we talk about non-pharmaceutical interventions. So it's thought that right now in Washington State, we're somewhere in that red square under acceleration. And it's imperative for us to be focusing on our effort to keep us there, to therefore prevent that rapid acceleration, to give us that real peak of cases, slow the process down. Why? Because I've got limited resources. I've got 4 hospitals. I can't tell you how many ICU beds I have. I can't tell you how many ventilators I have. But if the numbers reflect here what they reflected elsewhere, we're going to be pushing the envelope on who we can care for. And as I get a system, a healthcare system that gets stressed out, it can't do its routine work. So as a public health official, my priorities are, again, ensuring that everyone here and in my community stays healthy and has access to resources. But they have to have access to resources. And if those resources are being brought to bear and flooded, then as I said, it's not going to work. One of the metaphors that one of my friends talked about was that, if you're in a heavy rain, you're out there and all of a sudden you get 5 or 6 inches of rain in downtown Spokane. Well, now we've got the CSOs, so nothing floods, but you flood the streets. If, however, over the course of a couple of hours you get the same amount of rain, the system's able to tolerate that. That's what that's what we need to be doing for the healthcare system, to be able to take on the burden of this illness and ensure that those individuals who need to be cared for are cared for appropriately with the appropriate resources, but also everybody else who's dependent on the healthcare system is getting the kind of care that they need and deserve, and again, that we provide in our healthcare organizations. So we've gone from a low risk, low to the general population, to a quote-unquote tremendous risk. We've gone from what was not a pandemic to now a pandemic. We've got, again, this incredible spread across the country, and now, again, the focus is, at first we were trying to contain it, but now we're really trying to, at some level, mitigate it. Containment means that I'm trying to identify 1 or 2 cases, and then I'm identifying individuals who are in contact. So it's called a contact investigation. We know that the priority should be on maybe the first 6, 7, 8 people, the closest contacts with folks. But again, with this, we need to be moving from containment, because now that it's here, I need to be looking at mitigating strategies to keep myself lower on that bell-shaped curve. Again, this is an outdated slide. Community spread very likely to occur. No, it's here. I mean, that's what we're saying, it's community spread. And by community spread means that I have no obvious risk factors. So early on, we were talking about travel histories or contact with someone who has had that travel history. Community spread means I have no idea why this person was diagnosed with this. No obvious explanation, but it occurred, and that's what we saw on the west side. And you probably read maybe the New York Times article this past weekend about maybe the flu study. Did anybody see that article? The Seattle flu study? Another exercise in frustration. So back, as you know, the first case of COVID-19 was identified in an individual who was in Everett, and he had a positive travel history. So he, very astute physician, had heard about it, made the diagnosis, he was hospitalized, and did well, although at about the 7th or 8th day, a otherwise healthy individual goes into what's called acute respiratory distress syndrome, basically shock lung. And he did very poorly. They used an investigational antiviral medication that was not successful for Ebola, but may have been effective here, and he did fine, and he was discharged. Concurrent to that whole episode, there was a study that was going on. There was a researcher over at University of Washington who was studying flu, and so she had all of these specimens that was looking at flu. And she's thinking, as this is occurring, you know, I've got the specimens that I could use to be testing for COVID-19. Well, she wasn't allowed to by the federal government. They said, no, your study was specifically focusing on flu, and that's the only thing you can use these specimens for. So she's like, so she's watching and watching and watching. And again, we have no cases, mind you, at that time. No other cases identified in the state. And she's watching and she's watching and she's watching the numbers go up elsewhere. And so she goes, you know what? I'm going to test for it. And so she was able to actually test for it. And you know what? When you heard about the 17-year-old or the high school kid up in Everett, that was because he was one of the kids who was tested through her flu study. Okay. So all of a sudden she's able to test and she finds that, oh yeah, and there's an exact genetic match between the viral strain that was in that first patient and this kid who had no contact with him whatsoever. Community spread had been occurring for weeks, and nobody had been able to test for it. So again, that's sort of the frustration that I mentioned to you before. We knew it was going to come. We knew the travel history was significant enough for it to be here. We're seeing it primarily in metropolitan communities like Seattle. We knew it was here. We just couldn't make the diagnosis, and now that we know it's here, we're kind of playing catch up. So this is what I mentioned about containment. You identify all cases ideally, and then you really try to focus on their contacts, so you really try to keep it contained. Difference between isolation and quarantine. Isolation, you have it, I'm going to isolate you. Quarantine means that maybe you've come in contact with someone who had it. I'm going to quarantine you to prevent you or prevent you from coming in contact with somebody else. A little bit of a difference. Speaks for itself. I didn't know that slide existed. I could have. And then there was light. So that's where we are right now, mitigation. I know it's here. I'm trying to slow the progression. I'm trying to keep it lower on that bell-shaped curve. And importantly, as I mentioned, it's preparing the healthcare system for the inevitable and ensuring that the resources are available for everyone who needs it, both those who are impacted by this illness as well as everybody who needs it on a routine basis. I think I'd catch on which way to push these slides. So again, everybody, I did take note. There is Purell out here, and almost without exception, everybody who came in clean their hands with this. Again, it's 65 and 95% alcohol-based solutions, good old soap and water. Just as good, you just gotta do it long enough. So as I said, but good hand washing, good hand hygiene, social distancing. You're perfect where you are, Mark. Stay where you are, and everybody stay away from him. You are way too close. So, and nobody's in the back. Typically I would be in the back, but as I said, social distancing. Postponing or canceling mass events, and I'll talk to you a bit about this in a minute. This is contentious, but for me, this is a priority. You may have heard that there was a basketball tournament that was coming to, not the NC2As, but there was a middle school basketball tournament that was coming to Spokane as of, today is Thursday. The promoter was here yesterday morning. I talked with him on Tuesday. He tells me that he's got 500 teams coming from across the country. He's got 12,000 people estimated between kids and family members. I don't feel good about this. I don't feel good about this. And so I pulled the plug on it, and I apologized to him profusely. He had committed, a lot of money lost, but again, from a public health standpoint, it was the right thing to do, you know? And I will never be able to know whether or not doing that impacted the number of infections. I'd like to think it did. And I know based upon evidence and science that it did, but I can never prove that. I can't prove a negative. So social distancing and then environmental measures, and we'll talk about this in a minute. So again, non-pharmaceutical interventions 1 through 5, straightforward. So again, hand washing, respiratory hygiene, coughing etiquette, social distancing, clean and disinfect surfaces. These are what are called fomites. Stuff does stay here. Don't do that. And again, common sense. If you're not feeling well, stay home. So Washington State, we have 3 tiers. Tier 1 is go about your business. Everything's fine. Tier 2 is, you better start being a little bit more cautious about what you do. Why? Because we know that the infection is out there and it's been identified in a couple of counties. Stage 3 is all hands on deck. Tier 3 is all hands on deck. We have been in Tier 1 for quite some time. Seattle, King County has been in Tier 2 for quite some time. We as a state, I would argue, are teetering on the Stage 2, Stage 3. And I think that's the approach that I'm taking. That's the approach I need to take to really prepare us and to prevent us from that going up in a bell-shaped curve. Because I think it's complacency that will do us wrong in the end. And so it's this fine balance between not panicking, but also making people aware that this is not just your everyday cold, and you have to prepare accordingly. And it's a tough message to sell. It's a tough message to sell, folks, because again, I have a lot of people, I mean, even just, it was kind of funny yesterday, as I was walking my dogs at night, I was talking with one of my neighbors, and one of my other neighbors drove by, and she goes, "They canceled the basketball tournament. I can't believe they did that. What jerk did that?" And I was like, well, all right. Because her son plays basketball. Her son was going to be in the tournament. Sorry, you know. But by the same token, I can't tell you the number of death threats that the special PFD, Patrick, what's the PFD stand for?
Public Facilities District?
Yes, it's been a long day. Public Facilities District person has had. You're gonna bring COVID-19 to this community? You can't do that. You can't do that. So it's these kinds of things. I mean, I would say that as a society, we have difficulties with risk perception, and we fear what we don't know, and this is novel, and we're not familiar with it. And that tends to drive a lot of people's experience, a lot of people's risks, and how they react to it. So we talk about voluntary versus involuntary. Voluntary isolation. Please stay home. Please isolate yourself voluntarily. RCWs, Recognized Code of Washington, and the WACs, essentially these are the statutes by which we all live. And the health officer at the state level and local has a lot of authority when it comes to public health situations. And so if you choose not to stay home, I can make sure you do stay home. And I can actually write a health officer order that would require you to stay home. You say, you know what, I don't really believe in that piece of paper. Well, would you believe that piece of paper if the sheriff presents it to you? And if you say, no, I don't really believe, even if the sheriff presents it to me, then I say, well, how about the Superior Court? Because essentially it's a misdemeanor. And again, if you escalate it, it can be escalated up to the Superior Court. So again, my job, if you look at the RCW, says I'm supposed to preserve the health, wellness of the entire community. And it gives us a lot of statutory responsibility to do that, including the ability to actually put people in jail if they refuse to do that. For example, tuberculosis. So that's kind of heady stuff, and I never want to do that. I never want to do that. But I also want to ensure that people are willing and understand why they need to be followed through with some of these recommendations. This is where it gets a little bit touchy from a community standpoint. So again, the basketball game as an example, but you're seeing a lot of promoters already doing this. They're canceling events. I mean, unheard of, canceling the NC2As, March Madness. First it was, I actually was supposed to have a phone call with the medical director for the NC2A yesterday, and I'm on the conference call and there's nobody on the conference call with me. Because 5 minutes later they had already made the decision that they were going to have games with no fans in the stands. And then I heard that today they decided to just pull the plug completely. You know, AAU volleyball is canceled. Obviously, professional sports have been canceled. Disney World is canceled. Disney World is closed. Unheard of. But that's how people are responding, and to some degree, I give them credit because, again, I think that we've taken this too lightly. Anecdotal evidence has shown that those countries, like Singapore, like South Korea, that have really aggressively looked at social distancing and canceling mass events, their curves are much lower, their curves are much flatter, and their mortalities are much less. And so I am pleased to see us taking those types of efforts, but they're not done lightly, and oftentimes there's some pushback. So let me get to this slide. I think it's maybe I missed the slide. I apologize. I wanted to go through this. I must have missed it. I apologize. The issues right now that we're most concerned about, that are concerning me, are mass events and school closures. School closures are huge because they impact not only the children, but the teachers, the families. All of a sudden you have parents who are able to go to work, but now all of a sudden they have to deal with daycare. There is no daycare available in this community. You know, so it's a huge disruptor to the community. To date, we've not seen the majority of infections in young people, but today I learned that of the new positives, 3 are in young people. So it does occur. So school disruption is huge, and as I said, events. So it's really important for me as a health officer and for us as a health department and us as a community to understand that the best way, the most effective way to mitigate this effort, or to mitigate this infection, is to really work on social distancing, work on, again, canceling events and or giving people lots of space, and then trying to prevent it from happening. The next, there's 13 of these NPIs. You've heard about the issue back in, I think it's New Rochelle, New York, where they've essentially put a 1-mile quarantine around a community. And so it's called a cordon sanitaire. And so they're basically keeping all people in. You know, it's what they did in Wuhan. 11 million people who were sort of locked up in one city. Pretty crazy. I hope we never get there. I don't think we will. I think as a society, we would be hard pressed to make something like that work. But those are the extreme measures that, again, if push comes to shove, that's what we would have to give consideration to. So, I haven't figured this out yet. This is kind of a, as I mentioned, for us the focus is on healthcare, and we talk about conventional conservation strategies and crisis standards of care. Conventional is, as I said, every day, this is what you do. You go into a hospital, you can expect that you're going to get treated. You expect that they have all the resources. Right now, the West Side is on contingency containment. Okay, they don't have enough PPE, personal protective equipment over there. They're having to reuse. They're having to, again, conserve. They're having to figure out how they make best use of what equipment they have. They're getting to the point of actual, what's called crisis standards of care. I make those critical decisions. You know, who gets a ventilator? Who gets an ICU bed? That's how bad it's getting over there, because again, they've been inundated, overwhelmed. The system has been overwhelmed, and they haven't been prepared for it. You know, when I talked with my colleague over in Seattle King, Jeff Duchin, who I respect immensely, he's an infectious disease specialist. He understands this, and I called him up 2 days ago. And I said, Jeff, if you know now when you started this a couple weeks ago, when it all hit, how would you do things differently? He'd go, I'd be a lot more aggressive. I'd approach this a lot more aggressively than I did now. But it hit him so quickly that he just had no time. And so that's where I talk about the social distancing, the mass gatherings, things of that sort. And that's what he recommended to me, and that's what I'm really going to be encouraging throughout our community. So this is where we find ourselves right now. It's not a happy time, but again, I think the thing that people need to know is that the best way that we can assure the health of our community is to prepare accordingly and really ensure that the healthcare system is able to take care and have the resources available to ensure that the health of the community is kept positive. So, fatality management, we just started talking about that today. You know, but that's again the reality of it. We know that a percentage of individuals who are infected with this will succumb to it. And so how do you manage that? So we're not talking about mass fatalities, thankfully, but individuals, how do we deal with that? And again, it's something that public health works with, unfortunately. Oh, I still can't figure this out. One of the things, we talk about stigma, and this has been a big issue early on. I even heard a couple days ago, and I won't say from where I heard this, but it did come off of Fox News, that it's called the China COVID or China coronavirus, something like that, the Chinese coronavirus. And so when it was first identified in individuals who were coming from China, the stigma, and all of a sudden, oh my gosh, you're Asian, you know, and that's the stigma that's been associated with this. We've become, unfortunately, a very xenophobic society, and if we can blame somebody else for the issues that we're dealing with, then we're quick to do it. And so early on, we identified, we were hearing about the stigma associated with this, and so part of the Department of Health's efforts, and as well as locally, is to again eliminate stigma. So again, I think that's an important take-home message for all of us. That's it. Uplifting. That's Bob. You know, I'm staying in my lane. Happy. So, questions? Yes, ma'am. Yes, ma'am. With the black glove.
Before we start with questions, let's give Bob a big round of applause.
I will tell you there's a lot to be said for caffeine and chocolate.
Pretty good for 2 hours preparation, don't you think? This is really timely and good. Mark, can I ask you to hand the microphone over there? Now, we're going to turn this over to question and answers. We just have a couple of ground rules. Please, so everybody has a chance, one question at a time. And if you need to make a statement to frame a question, please keep it short. Okay, we only have one speaker here. All right, so who's got the first question? All
I have
right.
a question first, though. Should we really be sharing microphones? Can't we just use our voice?
Well, you can because you have a loud voice. Can everybody hear?
I have a teacher voice. I can.
I have a principal voice.
And my wife was a PE teacher, so she has a PE teacher voice, so I recognize those voices quite well.
Scott?
If anybody needs to use a microphone, perhaps Dave or Mark could just hold it for them.
Okay. Fair enough.
Okay, my question is, if you have to isolate at home and you have other people at home, how do you prevent them from getting what you've got? Do you stop cooking? Do you stay in your own room and order out?
You could.
What would you recommend?
Well, what kind of food do you like?
My own cooking.
Okay, yeah, I mean, so one of the things that I just was traveling last week, and the variations on themes of masks is really impressive. I've seen some very fashionista masks. I saw beautiful black masks. I saw some masks with like skull and crossbones. I saw a turquoise mask with sort of rhinestones on it, totally ineffective. I did see a bandana, so variations on themes. I did see some N95s. With this, if you are trying to protect yourself from getting infected, i.e. sort of quarantining yourself, then you need an N95 mask, okay, which you can't find anymore, okay. But if you're home and you're self-isolating, you essentially approach this in two ways. First of all, the surgical mask or the dust mask that you find at Ace Hardware, those are effective. Why? Because it's respiratory particles primarily. So you put something across your mouth like this, and when you cough or sneeze, you're going to be coughing or sneezing into that mask. For that matter, a bandana is fine for self-isolation, okay? If you have other people around you, however, again, that's where, again, your concerns, and so people have to give that appropriate distance. What we're seeing is that these respiratory particles travel up to about 6 feet. And so you've got you're there. I'm going to walk around you. I'm going to try to give myself enough space. Now, as I mentioned to you, we're learning more and more about this, but that's sort of the recommendations right now, that again, you give yourself space, you give people around you space. If you are living with other people, then again, you try to give them and give yourself enough space to kind of work. But, maybe you are ordering out, and maybe you are doing things differently. I think it's going to, again, there's no right or wrong answer, other than really trying to give yourself enough space and give other people enough space.
But if I'm the one who normally cooks and I'm the one that's sick, I shouldn't be the one that cooks.
Correct.
Okay.
Yeah.
Or clean.
Wait a minute. I think there's another message you're trying to send here.
I'll say you told me I should.
Yes, sir.
How's the disease progressing in Wuhan right now? They've had it a lot longer than us, and now where are they in their... They
had less than a dozen cases the other day. At about 2.5 months, it's dropped off precipitously. Why so? Is the fact that a significant percentage of individuals actually got the infection, and therefore there's just nobody else to get infected? Is it because of the mitigating efforts that they took? Is it a combination thereof? But at about 2.5 months, the numbers started dropping pretty precipitously. And I want to say, like 2 days ago, I saw that there were only 12 new cases. So,
any news from Italy?
Italy, again, is still on the uptick, unfortunately. Italy, and as I said, when I looked at it yesterday, and the numbers I don't remember now, but I mean, there was over 1,000 individuals, I want to say it was about a 6% mortality rate. So why higher? I don't know if it's affecting a different population, but pretty significant. Yeah, it has been Italy, but then you look at the South Korea experience, very, very different. They did a lot with testing. They quickly tested individuals. You may have seen the articles where they had literally drive-through clinics. So they literally drove up in their car. They had a healthcare worker who was decked in PPE, went out, swabbed. They had their own tests, they had quick turnarounds, and they were able to identify individuals, isolate them, made sure that they weren't the individuals who were doing the cooking or the cleaning, and maybe had somebody else do that work for them. And again, they've had a sort of flattening of their curve and doing much better. So,
Doug?
Ordinarily, by past experience, PEG sometimes gets significantly larger audiences. What conversation, if any, did you have about whether to call this event off?
2 hours ago, it was we flipped a coin. Pretty much.
yeah. I think it's, I mean, again, I think it's a very good question. I think, I think to the credit of, I think people in the local community are starting to feel a little bit more concerned. And I'd like to think that maybe there would be more people here had this not occurred. Maybe not, I don't know. But I think it's a very reasonable question. And again, I think that going forward, you will hear more from me over the next week, over the next 2 weeks, about different approaches to gatherings such as this. I think, again, as I've shared with you, I'm trying to get in front of the curve. And the only way I can do it is to really prevent mass gatherings. This does not constitute for me a mass gathering, and I also could have asked all of you to sit every other chair. That would have been a way to, have the same number of people in here or more people in here and yet still maintain that social distancing space. But I think, again, as a community, one of the messages that you'll be hearing from me and the health department is that we need to be more aggressive with some of these non-pharmaceutical interventions going forward if I'm really going to keep the curve flat.
This gentleman right here.
Some airplanes are still flying. Is it more dangerous to be on an airplane than other places because of the air circulation, or do they clean that up?
In a confined space, with, how many times have you been on an aircraft and you have somebody who you think has tuberculosis right behind you? Mm-hmm. It happens all the time. It happens.
But I heard they have
Sir, I'm sorry. The question was whether or not flying and being in that contained airspace where you have recirculated air is more at risk. Obviously, a lot of airlines have really gotten hit hard. They're canceling flights. First, they canceled flights to China. Now I've heard you can't come back from Europe unless you're a U.S. citizen. I don't understand why that exists. But that said, a lot of airlines are realizing that we're not going to risk the possibility of flights. And having just flown through the airport last 2 weeks ago, you definitely see a lot fewer people, rightfully so. So if you're asking me for a recommendation, don't go flying anytime soon and don't go on a cruise.
What are we doing to be able to test more people who are likely to be positive? How to decrease the backlog so that we have accurate information about the incidents in Spokane?
Yes, so the question is around testing and increasing testing capacity. So as of last week, LabCorp and Quest came online on Monday and LabCorp came online on Friday. The Public Health Lab has been testing. They liberalized the testing criteria. Early on, there were very, very strict criteria that were put out by the CDC. So I look back a couple of weeks ago, and when the CDC made tests available to some state labs, Washington State, given it was the first state with an identified patient, was given the test kits. Unfortunately, we couldn't validate them. And so sent them back to the CDC. And it took about 2 or 3 weeks for the Public Health Lab to come back online. The University of Washington concurrently was validating its test. It's coming up, it's ramping up. Oh, and then when it tried to validate its specimens against those confirmed from the Public Health Lab, there wasn't good congruency. And so only 6 of 10 actually ended up testing positive. And so University of Washington had to recalibrate its whole system. That caused a huge backlog. And so last week I literally had hundreds of specimens sitting at Public Health Lab that weren't being able to get run. And it's been a huge issue. University of Washington is now up and running. They're hoping to get up to about 1,000 tests a day, if not more or so. Hopefully by the end of this week, Public Health Lab is back up and running, and so you will start to see more and more of this. And so it's my sincere hope that over the next week, at the minimum a week, that we are seeing a significant amount of testing done. For me, there is a concept called sentinel testing. So I need to be able to understand at a community level the prevalence of the infection. Okay. Then there is also just the routine testing. Okay. So you have symptoms. Okay. Do you meet the criteria? In the past, the criteria have been very strict as to whether or not I will test you. Now it's provider discretion. And we're encouraging providers for the reason that I need to know what's out there. So I'm encouraging providers, if you go into a clinic, you'll get what's called a respiratory pathogen panel. It's all different types of viruses. And also you should be tested for COVID-19 if you meet the criteria, i.e. you've got fever, you've got lower respiratory tract symptoms, but I'd encourage providers right now to liberalize that. Conversely, what I don't want is everybody who comes in saying, you know what, I feel like I've got a runny nose, can you test me for COVID-19? And it's that fine balance. So it really comes down to provider discretion.
Marilyn?
In one of your later slides, you phrased it, the health of the healthcare system. And I've been thinking about this since this was coming to light in January, about just how I think we're going to be likely to see some real disparities in access to health. And, you know, just even some of what you just shared about the University of Washington, you know, and then not having their testing calibrated well enough to come up with congruency with the other tests. And so, I mean, what are your thoughts about the qualities and the access for our healthcare systems for all of our people?
And so the question is about the health of the healthcare system. I honestly can't take credit for that nice line, because I did co-opt this PowerPoint. But that said, I think it's a really important point. You know, we know that disparities in healthcare exist across this country, across the state, and across our community. You know, I see it on a daily basis. I'm in public health, and I take care and I work with some of the most marginalized individuals in our community. I mean, talk about the political rhetoric last election cycle about the homeless, you know, and yet, you know, I say that the homeless don't usually want to be homeless. They didn't wake up and say, you know what, I'm going to go be homeless today. You know, and they don't all have substance abuse issues, and they all don't have behavioral health issues. Again, a political statement aside. So I do have concerns about access, and if you can't get to the doctor, you can't get to the clinic for any number of reasons. Transportation is a huge issue. You know, we know that's one of those social determinants of health. If you can't get access, then you may never be tested. Now, granted, 80 to 85% of these individuals are going to be minimally symptomatic, but I have concerns with some of our minority populations in our community who have poor access as is and have been marginalized in our community. And so how do I ensure they get tested, you know? And in some of these vulnerable populations are, again, in close proximity. So for us, a population that we're working very, very closely with is the sheltered and the unsheltered homeless. You know, and working with them, we're pretty much in contact with the shelters on an almost daily basis, on working on how they can, you know, provide PPE, look at those non-pharmaceutical inventions, how they can ramp up the sanitary areas. You know, just an aside, I mean, how many of you know that there's been a hepatitis A outbreak in our community? And it's huge. I mean, I have 80, as of last week, I had 85 individuals who had been diagnosed with hepatitis A. And of that, I've had 3 deaths. Okay, and who have been diagnosed, they are 80 to 83% of them have been homeless and or substance users. You know, and homelessness is not a cause of hepatitis A, but it's an accelerant of hepatitis A. Why? Because they don't have access to basic sanitation. You know, so you walk around downtown, where do you go to the bathroom? There's no public facilities. And we pushed hard in August I had 25 individuals, in September I had 53. In October, I had 80 some individuals like that. There was my epi curve. And I'm like, why can't I get porta potties in Riverfront Park? Very frustrating, very, very frustrating. And yet I would argue that if I had had more access to those types of facilities, I could have potentially blunted the curve. The most important thing we did from a public health standpoint was vaccinations. It was a very successful vaccination for hepatitis A. I have an incredible group of people that I'm fortunate enough to work with. And we have been doing street outreach. You know, as of last week, we had done something on the order of about 2,400 vaccinations over this community to about 2,200 unique individuals. And that's not only those individuals living homeless, but it's also the workers, the people who work with them, working in shelters. We did a vaccine blitz in the jail back in October. I haven't done vaccines in quite some time, but we vaccinated more than 700 individuals between the jail and Geiger. In the jail, it took us an hour and a half to vaccinate 400 people. We had
That's
huge.
worth applause.
Yeah, and trust me, my team has just been incredible. I am truly blessed and fortunate to have such great people and dedicated. You know, saying that a public health professional is not passionate is an oxymoron. It doesn't happen. So anyway, to your point, disparities exist, and access to care, access to treatment is going to be an issue for this going forward. Yes, ma'am.
I think it may be helpful for some of us to remember that there have been public health issues around tuberculosis, polio, and Spanish flu. Can you comment on compare and contrast how we dealt with all of those things?
Oh gosh, so the question is around public health crises, around infection and contagion, such as the Spanish flu of 1918, 1919, 1920, tuberculosis, and the other infection was polio. Polio, yeah. Going to make me go into my public health history annals. Obviously, the Spanish flu of 1918, it was interesting last year reading the 100 Years in Spokane by Jim Kirshner and listening and reading about what was going on back then. People didn't understand about Spanish flu the way we do now. But it had a much higher mortality than what we're seeing, for example, with H1N1. But again, how it was managed, how it was treated was very, very different. Obviously, there was no treatment other than supportive. And so what we saw with that flu was that it overwhelmingly caused pulmonary edema, fluid in the lungs, which caused people to die. We didn't have respirators, we didn't have ventilators, we didn't have the means, we didn't have antibiotics, and sometimes it was a complication of a bacterial infection on top of a viral infection that caused people to die, but they died very quickly. And one of the things that I've always found fascinating is going to small towns and looking at old cemeteries. I remember years ago I found myself in Northern California, and I was in a town called Eureka, and I went to the cemetery, and it was heartbreaking to see the number of people who had succumbed and the infants who had succumbed to flu in 1918, a very different environment. Polio, truly one of the success stories. Vaccinations, and some of you may remember, maybe some of you actually lined up for vaccinations back in the 50s. Yeah. My mother unfortunately didn't, and so she ended up contracting polio. And so for me, when I have the anti-vaccine people show up at my Board of Health meetings and talk about the evils and the perils of vaccines, for me it's really personal. My mother ended up having polio, and she ended up dying of post-polio syndrome. So for me, it's very personal. But polio was a success story. And, you look at the worldwide eradication efforts around polio that have been, Bill Gates and also the Rotary. Phenomenal. And then unfortunately, this past year, we've had a slight uptick in polio, but success of vaccination. Tuberculosis. Tuberculosis is an incredibly virulent bacterial infection. It's one of the top 10 leading causes of death worldwide. We don't see it in this country. 80% of the cases of tuberculosis in this country are in individuals who are foreign born. They're coming from areas where tuberculosis is endemic. And so one of my responsibilities as a health officer is to manage cases of active tuberculosis in this country, but we are in this county. But there's also a lot of marginalization of those individuals because, again, they are foreign born. And so they are ostracized, and TB has a lot of stigma associated with it. By the same token, I can treat it. I can very effectively treat it. And so, a lot of public health work that we've done historically as well as going forward is around contagious and infectious diseases. This is one that, again, I think is interesting to watch. I don't have a treatment for it. It's truly supportive. But again, the public health efforts are, again, similar in that I am trying to contain it by doing contact investigations when I have an individual case or two, and then mitigate to prevent, again, sort of an overwhelming, ensuring the health of the healthcare system. So.
Now let's see, Dean?
Yeah, we understand that the clump in Seattle, King County, was around the extended care facilities. We have one that's in Spokane known as the jail that has about 70% of the people are waiting, not even convicted, waiting for their trial. What is going to be done to deal with that population to mitigate the COVID-19 impact of the jail?
And Dean, it's good to see you again. I think the last time I saw you was in a conversation about the jail. And where am I going tomorrow?
Good.
Yeah, we actually, to the credit of the jail staff and to the credit of Commissioner CUNY, who, as you know, has really taken on the jail to heart and really trying to ensure the health of the individuals in the jail. We met with jail staff on, today is Thursday, we met with them on Monday. And one of my epidemiologists, Mark, and I have tag teamed, and so we've been in front of staff. I'm going there. I'm going to be at Geiger tomorrow morning at 6:30. I'm sure I'll wake up in time at 6:30, and then at the jail at 7:15 to talk to staff about how to address the issues. As you know, it's when I talk about vulnerable populations, it is one that, again, I'm very concerned about. By the same token, it's somewhat of a unique situation in that when I talk about containing a population, if I have individuals who end up being diagnosed there, I have sort of a means by which I can contain them. Okay. And so what we are doing is we're sort of setting up a system whereby they have two negative pressure areas where, again, if I have one patient, two patients, they can be managed for those couple of days while we're considering somebody who is testing positive. We're considering them infectious. They're infectious until they've been fever-free for 72 hours, off of medications, and or asymptomatic for 7 days, whichever takes longer. So if we have two individuals, we have 2 rooms that can maintain those individuals. If I have more, then what we're going to be doing is essentially identifying a module where we can sort of isolate those individuals and then identify an entire module if needs be. And then working with the staff to really, identify individual staff. I'm fitting the staff with N95 masks, and we'll have a half dozen staff that are dedicated to just caring for those inmates. So to your point, we've actually identified them, and again, the very first meeting that I had on Monday when I got back in town was with the jail staff. And again, to their credit, they reached out to me as I reached out to them.
Mark?
I know I had a gentleman this morning was saying that of the number of people who had passed, how many of them would have just died anyway, because they already were fairly compromised. So you've spoken of those who are vulnerable. What about younger people? Are they also at risk too? And would you say a little bit about how this is different from the influenza? Because I'm having a number of people just say, it's going to go through the population, what's the big deal, they're making it, just get it over with.
I don't know if you saw one of the previous slides that I had, but I mean, certainly the case fatality rate is significantly different from the last, excuse me, H1N1 flu. Excuse me. Right now we're saying there's a case fatality rate, which is difficult to calculate because I don't know how many people truly have it. But, we're guesstimating a case fatality rate of 2, 3, 4% versus 0.1%, 0.01% for H1N1, which was the last bad, quote unquote, strain of flu. It's very different. It's a very, very different bug. Yes, it is disproportionately impacting in a severe way older individuals, especially older individuals who have medical problems. I can't tell you whether or not there have been deaths of younger people. I know, for example, however, that the individual who was the first case was in his 30s and he ended up in the ICU almost intubated. So it does not discriminate, but certainly for those who are impacted the hardest, they oftentimes will have those other medical conditions that make them just much more susceptible. I would strongly encourage you to discourage the people that you talk to from thinking that it's just like the flu.
Thank you.
I can think of a couple elderly individuals, and in each case they have been scheduled to have a non-life-threatening medical procedure done, something that needs to happen, but you're not going to die if you don't get it tomorrow. Would you recommend that these individuals maybe stay away from medical facilities?
Yes, ma'am. Yeah, that's one of our recommendations at healthcare facilities and individuals. If you have an elective procedure, it's elective.
Okay.
You can have it in a couple weeks, in a couple months. I mean, we're sort of preparing, like from the healthcare system standpoint, we're talking about 8 to 12 weeks of really sort of hunkering down, of really being, that's what we're preparing for. So, my messaging that you will hear, my messaging that you will continue to hear from me is we should be prepared for a change in your daily living practices for up to 8 to 12 weeks. I hope it doesn't take that long, but I want people to be prepared, and I'd rather have them pleasantly surprised than to still be finding themselves at 10 weeks, wait a minute, how long is this going to last? But this is going to disrupt our lives. And I think we just have to, and again, the sooner people realize that, the easier it's going to be to kind of deal with life as we know it going forward in the next couple of months.
I'm going to jump in and ask a quick question. Bob, we're the people for effective government. So that's what we're all about, is effective government. So if you had a magic wand,
I do.
and could go back 6 months ago, what are 3 or 4 things we should have done to get ahead of this curve?
Well, 6 to 12 months, 6 months ago, we didn't know this, we didn't know anything about this. This just started in December. So, but we are, I think, ill-prepared for emergencies. The stockpiles of PPE are minimal. I don't have enough. I don't have enough masks. I don't have enough ICU beds. I don't have enough ventilators. Again, so we are ill-prepared for natural disasters, for public health emergencies. As you mentioned, I've not seen a pandemic since 1918. And very, very different than 1918. But the technology that we have it and used it well. We talk about, the best healthcare system in this country that costs about $11,000 per capita. And yet I don't have health outcomes of comparable nature to other countries, where $4,000 is spent on per capita. And I'm sure you've heard those numbers before. So I think that we should be better prepared, but we don't necessarily think far enough in the future. We don't think about this could happen to us. This could happen to somebody else, but we have all these resources, but we're not prepared for these types of disasters. We're not prepared for natural disasters. We're not prepared for public health disasters. And the public health system is woefully, woefully, woefully underfunded. We get on average about 2 to 3% of the healthcare spend for public health infrastructure. So in the state of Washington, we've talked about what's called foundational public health services. And it's been estimated that to just get us back to where we should be, the biennial spend is about $500 million. We get minimal. Okay, I get some from the county, I get a lot of pass-through funds from the state and from the feds, but we are woefully underfunded. So as an example, as you mentioned, Dave, I mean, I'm the health officer here. I've got a staff of 255. I'm also the health officer in Spokane County where I have a staff of 5. So how can I do what needs to be done when I've got a staff of 5? And foundational public health services include disease investigation, infectious disease investigation. So amazingly, I have no cases of sexually transmitted diseases in Spokane County because there's nobody to investigate them. So long story, long answer, short question. Better funding for public health, better funding for public health infrastructure, for emergency preparedness would have been where, again, I would have emphasized, and again, what I will continue to emphasize, hopefully a lesson learned, but we are not very good at learning lessons in our society.
Well, you mentioned about Korea, and they seem to me to be very efficient in dealing with this. Why is it that we are not as efficient? What are we lacking, especially in light of this just being more to come in the future?
So the question is around the efficiencies of the Korean healthcare approach to this. It's a cultural thing. I mean, I don't know how else to say it. I mean, they attacked it in the way they do a lot of things. They, as you said, efficiency.
Why can't we do that?
That's a rhetorical question that I really can't answer. You know, if anybody can answer that question, please chime in. We have to do things differently. We have to do things our way. I mean, and again, why do we say that we've got the best healthcare system in this world, and yet we don't have the data to demonstrate that? You know, so there's so many reasons why, again, I think the hubris associated with us as a society, and we do it our way. And I mean, Asian cultures are very, very different. It's an us versus a me. And that cultural difference is huge. Cultural difference is huge. And, you know, again, the fact that in public health, I care about the community, you know, and so for me, you know, I talk about the N of one. As a clinician, I care about the individual, the patient in front of me. As a public health official, I care about all 500,000+ people in my county, you know, and at some level, you have to realize that your individual rights may not trump, and I hate to use that, excuse my language, may not be better or more important than those around you. Okay, but that's not how we live. That's not how we function. It's not how we practice. You know, and I deal with this, the anti-vaccine rhetoric that I've been dealing with the last couple of years. You know, it's all about my child. It's not about everybody else's children around you. It's not a fact that your child is not vaccinated, and therefore that could impact the children around them. No, it's about my kid. And that, again, is just a cultural issue. So long story, again, long answer, short question. It's a societal issue.
2 more questions. Mike?
Thank you. I just want to ask, a question related to climate change and how much this would, is related to climate change, and do we expect more of this stuff to grow?
So the question is around the relationship between this infection and climate change. I would say earlier on I mentioned about what are called zoonoses, i.e. animal-borne infections, and this is a classic example thereof. You know, so one of the issues when we talk about climate change is around the fact that we are going to see more of these animal-based infections going forward, animal-based infections that we have no exposure to, that we are immunologically naive to. And so I think that, is this particular infection a reflection of climate change? Possibly. I don't know. But it is a reflection, if nothing else, of the fact that as an animal-borne infection, which has now been transmitted to humans, we will be seeing more of these undoubtedly as we go forward, both locally as well as nationally and internationally. I mean, so last year, hantavirus, which has been typically seen only in the Southwest, it's now in Northwest Oregon and in, Northeast Oregon and Southeastern Washington. It's a desert virus, but it's here, you know, and we know that West Nile virus is endemic, and yet it started back east. So as I said, I think long story again, my apologies. As you can see, I do this quite often. Get me started. We're going to see more of these types of infections going forward.
Yeah, Seattle Public Schools have closed their schools for 2 weeks. How close is Spokane been doing that?
Ooh. Yeah, is it just 2 weeks? I thought they closed them for longer than that. I think they're closed to the end of April.
I heard 2 weeks.
Well, they just changed, the governor just extended it.
Yeah, I heard that now the governor essentially
Closed.
to the end of April.
For Pierce County and King County.
Pierce, Snohomish, and King counties, the three counties most impacted. We're in conversations with the school district. They look to us for guidance. I would not at this point recommend them to close. What I probably would recommend and what I would discuss with them is more social distancing and things like maybe not having assemblies, maybe not having after-school activities, look at more spacing in cafeterias. If they can do stuff online, go for it, and really trying to prevent those situations where I'm going to get large numbers of young people in close proximity. But I am not encouraging at this time, and that's the caveat, at this time that the schools consider closing.
Okay, there's one thing we haven't talked about.
Just one thing?
That I think is important is the whole issue of civility in public discourse and discussion. And Dr. Lutz, from your standpoint, where have we gone wrong with regard to how we've communicated this to the public? And talk a little bit about the media's responsibility in that, in working closely with the professionals, the healthcare professionals, and also the politicians' responsibilities to...
There's about 5 different responses there. Man.
It's kind of sad when one of your own members doesn't follow.
But this gets at the core of what People for Effective Government is all about.
Point taken. Yeah, I think the media looks for sensationalism. They look for a quick sell. They're looking for like something that I gotcha, or it's a really exciting story. It's sexy, and at some level, I think they could have done this a little bit differently. I think we are locally fortunate, and I've been very fortunate to work with some really good people in journalism. A couple of really good writers from the Spokesman Review. I think highly of the reporters at NPR. And it was fun to see Nick DeShays, who used to write about traffic, and now Nick DeShays is at NPR, which is kind of fun. And it was good to see him when I gave the press conference. We were at a press conference around the individuals who were hospitalized here at Sacred Heart. He was one of the people who interviewed me. So, but so oftentimes the media is looking for something sexy. And I think they tend to exaggerate sometimes, but there's always that concern about exaggeration rather than just providing the facts. Public health lives by data, and data is not always sexy, but the truth is, and the truth is important. And if I misrepresent the truth, then people aren't getting the answers that they need to make informed decisions.
I mean, frankly, if we'd have had this presentation on all of our public airways, was a person like yourself presenting it and then answering questions, that the public could see this, because this was very educational tonight, and I would ask all of us, have we seen something of this caliber presented.
And I appreciate that, and I think again to my, I think I could have. I mean, again, this definitely, you know, to the credit of the agency, you know, we've been in incident command for almost 40 days, and I think we've been doing good messaging. Could we have done better messaging? Yeah, I think, you know, hindsight is always 20/20.
Well, I'm not suggesting.
No, but let me, but
This
no.
gets back to the issue of the politicians and the media and their role in this whole process.
But I think in that vein, I think had I been, and I put some onus on me in this regard. I mean, I am the face of public health in Spokane. I mean, for whether you like it or you don't, I mean, I am, you know. And anybody remember Ray Walston from My Favorite Martian? Do I look like him? So anyway, just an aside. But I think, you know, again, for me going forward, it's imperative that I get out there more. You know, so as I mentioned, I was traveling last week, but I was in front of City Council on Monday night. And I'll be in front of City Council every Monday evening going forward. You know, there's a press conference. If you want to stay tuned, there's a press conference tomorrow that I'll be giving. You know, I was in a press conference yesterday. It's essential that we get the word out. And yeah, I mean, I would like to think that people think of me as sort of a trusted voice of public health, and that I do speak the truth. And I think the truth is important to speak. And then I think it is important that I do have some good working relationships with people in the media. And I think they are representing me in the issues well. That's not uniformly across the community.
Let's give Dr. Lutz a big round of applause.